feedback on is the one about sepsis. So if you have time, I think it's about 11, 12 minutes. It will touch your heart in a way like no other. And you should look at it, especially if you're not totally understanding the effect it's having on people. And until it pictures your family, you won't. All right, so infective endocarditis, we're talking about which part? Inside of the heart. Okay? And the valves are on the inside of the heart, the inner lining. Remember that?
Yep.
Okay, so what is going on here? What do you think happens when the whole inside lining gets inflamed or infected? Does it disfigure your valves? Does it disfigure them? If it disfigures them, can they close and open like they're supposed to?
Nope.
If they can't close and open like they're supposed to, are you going to have turbulent blood flow?
Yes.
Yes. So might you hear a murmur?
Yes.
Yes. Okay. And if they had a murmur, their murmur is going to be changed. The blood flow is not going to be able to go through like it's supposed to. So if blood flow is turbulent, the inside is inflamed, do you think it's going to be like a strawberry on a knee where it's kind of denuded? Do y'all know what denuded mean? Where the skin's rubbed off, and now what happens when you have a strawberry on your knee?
It hurts.
It seeps stuff and it hurts really bad. So what's the things that come to the top in the form of scab? Like
Blood clot.
well, you're going to have platelets that are going there. And you know all the things that form scabs on the outside of your body? You know what I'm talking about?
It's like skin cells.
Okay.
Yeah.
So you're going to have a bunch of gunk. That's all you got to remember. On the inside layer of the heart around where your valves are. And not only can your valves not open and close good, now you got all this gunk there. And so that's the perfect little median, little house, so to speak, for any kind of bacteria that we allow in the bloodstream. From, I ain't even going to ask. If you got a piercing and they didn't do it real well, you think that might cause bacteria to enter your bloodstream? Yeah. Could it?
Yeah.
What about any kind of surgery, or you started an IV and you thought, well, I don't have to wipe them again with alcohol or chloroprep. I'm just going to stick them. What if you're abusing drugs and you just all you care about is sticking your vein? And do you think you're worried about asepsis? Mm-hmm. So what if you have abnormal blood flow through your valves, through the inside of your heart of any kind, and you got this denuded area from this abnormal flow? Are you at risk for infective endocarditis?
Yeah.
Yes, because here's what the little bacteria coming through your heart says. Ooh, looks like a condo to me. Let me get up in this stuff. And so all these bacteria, they seed, so to speak. They're like little seeds, and they get in all that gunk and live there. And on an echocardiogram, they call that, you'll read, vegetation. Okay? And so it's all that denuded area from all that abnormal blood flow, and now we've got bacteria growing and breeding and having little babies in the inside of your heart. So they call that vegetation. And over time, all that denuded area, it can cause scarring. So if the tissue is damaged and you got a scar, is that going to help the situation? No. So again, now we're at risk for embolism, and it makes sense. If now the blood flow, it ain't going through like it's supposed to, you got all this bumpy, lumpy gunk, and the platelets are part of it, are you at risk for embolism with this?
Yes.
Does that make sense? All right, so now if all these little bacteria are growing around your valve, what if it just keeps getting bigger and bigger? Could it obstruct your valves or cause them not to move like they should?
Yes. Yes.
Yes. So you see the problem here? So now let's look at what the patient presents like. With infective endocarditis, Infective. Is there an infection present? Yes. They're going to have things like a fever. One of the big keys to noticing this is that they will say a lot of times, I felt so bad, I sweat at night, I have chills, I feel bad. They'll tell you that, I don't know, I got something bad. It's funny. The patients that I've admitted, this is some of the stuff they say. And I say, oh, let me put my stethoscope on their chest and see if I hear a murmur. And that's kind of one of the diagnostic keys, is because they have turbulent flow. If they have infective endocarditis, I would expect to hear a murmur. And so the other things that are telltales are looking at their fingernails. Do they have those splinter hemorrhages? They look like someone took a black ink pen or a red ink pen, maroonish color, and I'll show you some pictures that mark their nail beds. That is not from a pen. That is splinter hemorrhages. Splinter hemorrhages. The other thing they may have is petechiae, which is those pinpoint little red marks. Check in their eyes. Check around their clavicle. Check their feet. Between their toes. You'd be shocked where you might find some petechiae. They'll complain that they have aches and pains almost like the flu. And so here are the other things. Over time, does it make sense to you that they're going to have signs and symptoms of heart failure? Because are they going to have heart failure if their blood can't flow forward like it's supposed to? Yes, over time. And they'll complain. The sad part is if they're throwing clots, they are at risk because they can throw a clot that cuts off blood supply to their liver. They can throw, so they'll have sometimes real pain, and it is significant. And it could be because they've thrown a clot and are cutting off blood supply somewhere. They can have a headache. Where does the clot go? The brain. Yeah. So look up here. The one on the left, top left, that's splinter hemorrhages. The one below it is looking into the eye, which you wouldn't be doing, but they'll say they have Roth, R-O-T-H, spots in their eye, so that's something the doctor can look at. But the other thing that you can see, and I always say you don't have to say what they are, is that at the top right is called Janeway Lesions, but they also can have another type of lesion on their hand called an osselar node. And so they'll either have, so I just tell the doctor, they got them lesions on their hand, and then let them determine which ones they are. The osselar nodes are more round, and they're also very painful. And so sometimes they'll go, and this hurts so bad, and they'll tell you, show you their hands. And so that is another sign of infective endocarditis. And so you may not know what they are, but just make sure you point out to the doctor that they have those on their hands. So go look at her hands. All right, so what are the causes? We talked a lot about the causes being injuries, right? Whether we did it or they did it to themselves. Think about the patient who has a congenital heart defect, that their blood is not going smoothly through their heart. Are they at risk for infective endocarditis? Look at me. Any patient that has any valvular disorder where their blood flow is not going smooth through their heart is at risk for infective endocarditis. Here we go. Valvular disorders. I just talked about a congenital heart defect, didn't I? Some patients are born with valve problems. Okay? You know how, have you ever met somebody, and don't hold yours up because I'm not trying to embarrass you. Have you ever met somebody who was born with webbed fingers or toes? I know somebody who is. And I dated a guy who his toes were webbed together. I thought it was the coolest thing ever. But anyway, you can be born with your leaflets of your heart valves webbed together. So you know how you're supposed to have leaflets that open and close smoothly? The area where your leaflets of your valves connect or come together are called the commissure. Okay? They're called the commissure. And there are some patients who are born with their commissure fused together. So maybe only one of them moves instead of the other. So I'm trying to tell you that valve disorders, your patient is either born with it or it's acquired. Okay? And we're going to talk about some of the things where they acquire them through their life. So with cardiac, up to this point, we've been talking about MI, hadn't we, and all those things. And we're talking about coronary artery disease. And family history was what? Significant, wasn't it? With this, no. The history that is significant with valvular disorder is the client themselves. You got it? This is very different. You need to know it. I wouldn't have wrote it up here in green. So valve disorders, you're born with it or you acquire it. So the client history is what's important, not family history. Okay? Their history. The client's history themselves. All right, so because I just talked about congenital, didn't I? All right. So, I didn't want to forget to tell you that. So if you've got a patient with any valvular disorder history, and we've treated, let's say it's the infective endocarditis patient, and we've treated them, and they're better. But now they need to go to the dentist and have a tooth pulled, an extraction. Guess what they need?
Prophylactic antibiotics.
Prophylactic antibiotics. For the rest of their life. Remember, it was oral or respiratory procedures. Y'all remember that? And so it ain't certain valve disorders, it's all. Got it?
So if they have a valve disorder, they have to have prophylactic antibiotics.
Before dental
Respiratory.
or respiratory procedures. And that's in your book. But I want to make sure you get it. So again, what are the causes of this infection on the inside of the heart? Here are all of these, and it should make sense to you. And then what diagnostic tests? Well, if it's an infection, do we need blood cultures? Do we worry about, and this is important because the biggest thing the nurse does is monitor the patient and the labs. So we report labs that are abnormal, don't we? And we don't call the doctor and go, hey, their sodium's normal today. Or, hey, their potassium's normal today. What are you going to get? Click. Or, what's wrong with you? You know what I'm saying? What do you call the doctor about? Abnormals. Okay. And with infective endocarditis, what are we looking at? What labs? Well, we're looking at their CBC because we're wanting to see what their white blood cell count is. And late in this problem, they may have a low H&H, so we're going to monitor their H&H. Okay? But the main one, when you're looking at an infection, is their WBCs, right? Y'all remember that? And the other test that you need to write in up here is an echocardiogram. And they're going to do it because they can see the valves, they can see the vegetation, they can see a clot if it's in there. You with me? So is an echocardiogram important for the endocarditis patient? Is a CBC important for the endocarditis patient? Yes. All right, so we got 2 so far. EKG may show some abnormalities. A chest x-ray is good. An echocardiogram is even better. All right, so lab's important. CBC important. Blood culture is important. All right. There's the echo. All right. And if we can't see the back of the heart, what kind of echo are we going to do?
GEE.
All right, good. So how are we going to treat this? And this is the important part. You ready? Yes. If they are acute infective endocarditis, they need bed rest. And if I told you that they can go into heart failure, they need a bunch of IV fluids. Does a heart failure patient need IV fluids? No. Do they need antibiotics? Yes, because they are infected. And y'all, they're going to need them for 4 to 6 weeks. So they're going to need a very good IV access. Okay? So if you're going to need antibiotics for 4 to 6 weeks and you are a IV drug abuser, you just give you a pick line and say, have at it, sister. No, they will put you in a skilled nursing home for your antibiotics. Okay? Ain't fun. I've seen it. So the deal here is maintaining an antibiotic concentration in the blood. Do y'all remember we talked about peak and trough? TDMs, those are so important to see if the antibiotic is in the right concentration of the blood to kill the infection. And we don't want it so high that it's going to also kill our hearing and our kidneys. Remember that? So what is priority for the endocarditis, infective endocarditis patient? Having a good IV and antibiotics for 4 to 6 weeks. Does that make sense? Okay. All right. So again, we're going to do antibiotics. We're going to get that under control. Now, if the valves are so distorted that it's causing a problem, causing heart failure, then they're going to go in there and see, after they get the infection cleared up, if they can repair the native valve. So the person's valves, can they go in there and clip, like a sewing machine, their leaflets so where they'll close better? Do we need to clean off all that vegetative funk and clean up the valve? Is it repairable? So they may do some sort of repair on their valves after that. If they're not repairable, then they will literally go in and do a valve replacement. Okay, once they get all this cleaned up. So does that make sense? So what's your focus on first? Getting rid of the
good idea.
That's right, and making sure that you're watching their peaks and troughs and their TDM, which is otherwise known as their TDM, therapeutic drug monitoring. Okay, so your assessment, health history, looking and finding all this stuff on their hands, and the complaints, recognizing the signs and symptoms are important. We're going to be recording their temperature, their vital signs, making sure we're monitoring antibiotics. And we're going to be watching for those signs and symptoms of heart failure and reporting if they're getting worse to where they're not preventable. So how do you prevent them from getting it again? You got to teach, don't you? Now what about their mouth? What about brushing their teeth? Soft brushable toothbrush twice a day, rinse with water. No, what do you call them things? Irrigating devices. I have one that I know that name. Water pick. No water picks. No floss. Okay? So all they can do is soft bristle toothbrush and rinse with water twice a day. Okay. Now, if this patient is going for a valve replacement, and I'm going ahead and throwing this in, and they have rotten teeth in their mouth, before they do any valve replacement, any procedures, they're going to have them go get that taken care of. I hope that makes sense. Okay? Any open heart surgery, if anybody's got rotten teeth in their mouth, they got to go handle that before the doctors will operate on their heart. Okay, so let's talk about this one real quick. Rheumatic endocarditis, and we call this now rheumatic carditis because we know that this problem occurs in all layers of the heart. Of course, the one that causes the most trouble is the inside layer because that's where your valves are. But in your book it says rheumatic carditis instead of endocarditis. The problem with this one is this one occurs after a bout of beta hemolytic strep. Group A, beta hemolytic strep. Who in here's had strep throat? Okay. If it's untreated or undertreated, what happens, and this happens to school age children a lot, if it's untreated or undertreated, then they can have rheumatic fever occur 2 to 6 weeks afterwards. And about 50% of patients who have rheumatic fever end up with rheumatic carditis. They're not sure why it happens. They think it's about related to the immune system and it's a sensitivity response. And there are actually lesions that occur in the heart on the inside layer. And these lesions are called Echocardiogram bodies. And if you have a bunch of lesions on the inside layer occur in your heart, the blood flow is going to be bumpy. So we're going to hear what? Bumpy turbulence. You're going to have turbulence. And so what are you going to likely hear first? A murmur. And so that's kind of how we diagnose this with clinical history. They talk about their sore throat and what happened, and then they got this fever. And so if they are reinfected is what has happened with what? Strep. They had strep, now they're reinfected with strep. And so what are we going to treat them with? Antibiotics, penicillin. And if they can't take penicillin, they get erythromycin. And this patient, you heard me say any patient with a valve problem gets prophylactic antibiotics. So is this a valve problem on the inside layer of the heart? Yeah. Do they need antibiotic prophylaxis for the rest of their life if they're having dental or respiratory procedures? Yes. So here's the signs and symptoms. They can have a rub. I heard somebody saying a rub. I wanted you to hear murmur first because that's usually what we hear first and more often than a rub. You don't always hear a rub, but you can hear a rub with this one, but I don't want you associating a rub with anything other than pericarditis, really. But I want you to be knowledgeable in the back of your head that this patient can have a rub, but may not always have a rub. Everybody got it? Okay. All right, yes, ma'am. And I got to keep moving because we got a ways to go and it's getting close to 3 o'clock.
Okay, this might not be a good
Well, you wait until after and I'll stay after.
I'll write it down.
Okay. All right. I will. We got to keep rolling. Myocarditis is occurring on the inside, right? On the muscle cells themselves. And I already talked a little bit about this and understand that this can occur after an infection. Like a parasitic infection, like if you went overseas, there's a parasite, Chagas disease, that this can happen. It can actually come from radiation from cancer or an immune response. And a lot of times people have this and they never know they even have it. They feel like they have the flu. But when it gets, if it involves a large part of the heart, then they have heart failure type symptoms and chest discomfort. And they will have ST and T wave changes on their EKG. Their white cells will elevate. Their ESR will elevate, which indicates inflammation in the body. And the only way to truly diagnose this is if they biopsy your heart muscle. So that's crazy. All right, I'm not going to focus too much on this other than to tell you when they're acute, they're on bed rest, and we monitor their temperature closely. And they're at risk for dish toxicity if they take it, if we use it as part of the treatment for their heart failure. And we got to prevent DVTs because they're going to be on bed rest a while. If it's related to an infection, we're going to treat it with antibiotics. And the way we treat the inflammation of the heart is non-steroidal anti-inflammatory drugs. And they think you're crazy when you come in there with their ibuprofen. They're like, I got this major problem, and you're giving me what? And so, but it does truly help. And so, again, they'll be at risk for dysrhythmias because it affects that heart muscle. All right, so here's where I want to concentrate my time and my air. Pericarditis. I talked to you a little bit to explain that pericarditis is an inflammation or infection of the outside lining of the heart. It can be chronic or acute. And remember that here's some of the causes. Oops, sorry, this is mine. It's crazy. After an MI, someone can have pericarditis. After any surgery, anything that insults the heart lining, any infection, any connective tissue disorder, and I've seen it from radiation in the chest. Someone gets pericarditis from that. So what are the signs and symptoms? They can be asymptomatic, but typically their pain's going to be worse when they cough, when they take a deep breath, sometimes even when they swallow, but definitely when they lay supine. They're going to have a fever. Their white cells are going to be elevated. They may feel short of breath and have signs and symptoms of heart failure. The big key here is you would expect elevated temperature, and you would expect a pericardial friction rub. Get them to hold their breath if you're not sure where the rub's coming from, because it's going to you'll keep hearing it if it's coming from the heart. Atrial fib is common with pericarditis, and they can have a rapid heart rate with it. What kind of diagnostic test? Well, the lab is going to show all kind of inflammation. So their ESR, which shows inflammation, and CRP are going to be elevated. If it's infection, blood cultures are going to be positive. Echocardiogram will show the inflammation, so if we can't see the backside, we'll do a TEE. So they'll do those other tests like a chest X-ray and a 12-lead. And here's the deal. With pericarditis, you can have ST segment elevation, but you're not going to have elevated enzymes, so we don't freak out. With pericarditis, they're going to treat them with non-steroidal or anti-inflammatory drugs. So you're going to go in there with something like Motrin, and they're going to go, I am hurting. And you say, this is the treatment, and it should help within 48 hours. And that is the treatment they're going to give them. They may give them a little something extra for pain if they complain too much. But truly, the only thing that's going to make them better is those non-steroidal or anti-inflammatory drugs. If it's not infective, they'll give steroids. They'll give them corticosteroids. But if they're infected, they're going to be careful with giving steroids. Okay? And so if it's from fluid buildup or in their sac, they're going to do the needle where they go in there and they do the pericardial centesis to release the fluid. The problem, the major complication that should be reported immediately that can kill them is cardiac tamponade. So their pericarditis, their form of it, they're having fluid all in their sac. If it builds up too quickly, they can have cardiac tamponade. Do you need to know the signs and symptoms of cardiac tamponade? That muffled heart sounds, JVD with clear lung sounds. Do y'all remember all that? Okay. And so, do you need to look up the pericarditis information? Yes. Yes. Make sure that you do. Pericarditis is one of the most common things that happens. We see it so much. Are you going to read that section in the book?
Yes.
Are you going to have the expected findings versus what you would report immediately?
Yes.
Yes. Okay. Septic shock. I love this little, there's your video. Do you have time to watch it? I don't have time to show it to you. I'm telling you what you need to know. You got a local infection. Are you at risk for sepsis?
Yes.
Absolutely. That's what it is. And then it can enter the bloodstream, and early sepsis is something we hope we catch because we recognize some of the Sears criteria found in your book in that table over there. And some of them are listed out on the board that we frequently see. And if we don't catch the systemic inflammatory response, they can actually go into severe sepsis where we start seeing a lot of anaerobic metabolism. We see that major vasodilation where they start third-spacing fluids and then they start to leak. After they start to leak. If we don't catch them, then they can go into organ failure and die. How you like that? Okay. So this kind of defines it for you if you didn't hear a thing I said. If someone vasodilates and starts leaking in their capillaries, are they going to require a lot of fluid boluses? Mm-hmm. Yes, just to keep their blood pressure up, their MAP up, and we're going to watch their urine output. And if you're giving somebody, like this patient we found at clinical, one of the last clinicals I went to, the patient was getting IV fluids at 150 an hour. He was 80-something years old, had no urine output. Is there a problem? Yeah. He had about 20 cc's in his urinary catheter. And here's what the staff said. I think we emptied that.
Oh my God.
And so then I said, is the catheter working? Is his bladder distended? Go get the bladder scanner. And so if the bladder scanner is working correctly, would it tell us if there was urine in his bladder?
Yeah.
There was no urine in his bladder. When we assessed him, he had a scrotal abscess. Huge. Could it be he's septic? Yeah. His heart rate was like 118. His temperature was like 101. And his respiratory rate was in the 20s. Had anybody noticed He had 0 antibiotics ordered. No one, he was admitted with a GI bleed, and there wasn't the first blood coming out of his head. His age was like 12 or 37. Do you think he had the wrong diagnosis?
Yeah.
Do you think I almost had a stroke?
Yeah.
I got that man off that floor. So I'm just telling you, I'm willing to work there. So again, this kind of stuff, I need your eyes, and you need to be the Army with me to be able to start recognizing some of this stuff. Okay? So again, the man, they said, was 80-something years old, so he was likely demented. He came from a personal care home. Guess what he was in? Sepsis. Guess what happened to him after a couple of days? He was better at it than y'all are. He was carrying on a full conversation after he was treated appropriately. It enrages me when nursing staff say, well, he's just old, he's demented. Well, does anybody know him? Does he have family? He was not demented. And so that kind of stuff pisses me off. Because I know a change in LOC is one of the what? Signs of decreased cardiac output. Could this man be septic going into septic shock? Yes. So again, once they go into shock is when you can see the problem with the clotting, the microthrombi that actually go and can clot up the capillaries, and they can cause more hypoxia to the tissue. So it's better to catch it early. You have this very narrow window that if we catch those signs that we can treat it, because if it gets to severe sepsis, the downhill slide happens very fast. So here's what I was telling you about, that you did not need to know all of these what? Phases. But look at the pre-shock phase. You don't have to know about the PAOP and the CVP. I don't care if you even know what any of that means. I want you to understand that in pre-shock, it's vague signs and symptoms that we might not even catch. You know what I'm saying? If they're not diabetic, or we even doing blood glucoses on them, you may not catch any of that. And then they move into a hyperdynamic where they're vasodilating, so they look warm. They don't look like they're having a problem with perfusion. But look at hypodynamic. This is when they're in severe sepsis, and this window is very narrow, so they can go into organ failure and die very quickly. So that's what I wanted you to understand from that slide. So septic shock is when they go into multi-organ failure. The mortality rate is even higher than 50. It says 50 on this slide. And so, again, I've already talked you through it. So let me relieve your mind to tell you Ms. Cooper is not hitting hard on cardiomyopathy, because cardiomyopathy is a very small section in your book, and you're only responsible for the ones on these slides, and it really doesn't matter, because all it means is their heart muscle is diseased. It's pretty much dead. And there's no real huge treatments to fix these things. The treatments the doctors will determine, okay, based on the type of cardiomyopathy. You will not. You as the nurse will treat heart failure. So no matter what kind of cardiomyopathy it is, you've got this weak heart that is not able to push blood where it needs to go. That's all of it, is heart failure, okay? So all you need to understand about cardiomyopathy is that they classify it according to what's going wrong, what is the structural defect, okay, and what's the functional problem. So if I told you dilated cardiomyopathy, you would know that that heart is what? It's huge, it's big, it's dilated, it's floppy, okay, and it's weak. It's big, floppy, and weak. And this is the most common type. The other type is hypertrophic. If something's hypertrophic, then it is huge. It's kind of like one of those guys that's been in there working out at the gym, but it's weak. It's all big, and so if I told you the muscle is huge and big, that doesn't leave a lot of room for blood to fill, does it? It doesn't leave a lot of room for the blood to fill in it, and then, so can a lot of blood pump out of it? No. The other problem is restrictive. So if I told you it's restrictive, can it relax and contract like it needs to and push blood out? Now let me say this. Dilated is the most common cause. And so you see that a lot of times for people who abuse drugs, who abuse alcohol. Sometimes it's related to an infection. Sometimes we don't know why the patient has it. So again, these are very sad situations because if it gets really bad and the heart's not functional, they're going to need a heart transplant. So there's not a lot we can do other than treat the heart failure. Does that make sense? The other thing I need you to understand is hypertrophic is the one that young athletes drop dead from. They don't know they have it. Sometimes it's genetic. And so if you know that your dad died when he was a child, would you not go and have your child checked or yourself checked? So all first line, when we find this, we test all first line relatives to see. And so again, hypertrophic. That's the one that young athletes just drop dead from. So we teach a lot. We teach that if they have palpitations, get dizzy, that their chest pain is not going to be typical like heart attack chest pain. And you have to believe your child when they tell you these things. So they're at risk for dropping dead. So do you think they might have an ICD placed? They're not going to be able to do sports if this is diagnosed because they'll drop dead if you push a weak, sick heart, won't they? So does that make sense? So cardiomyopathy, you're pretty much as the nurse treating what?
Heart failure.
Heart failure. There's pictures of these. There's the normal heart versus the dilated. And so here you go. You can read these slides yourself. An AICD is an implanted defibrillator that they put inside them. The diagnosis or the prognosis is very grim. They're going to need a heart transplant. Is everybody a candidate for a heart transplant? No. Hypertrophic, this is the one that the young kids will drop dead from. You can read those slides, but this is a picture of that big old heart muscle. And sometimes with this one, they can go in and do surgical techniques to remove some of that muscle and get more area for the heart to fill with blood. We can make some of these patients better, okay, with surgical intervention, but their heart is still diseased. Restrictive is the least common form. And so they're going to have signs and symptoms of heart failure and very poor prognosis, okay? All right, so let's talk about valves real quick. This is easy. Easy. Valves are either stenotic, which means they're what? Narrow. If your valve's narrow and rigid, can blood get through it? No. And when I'm talking about mitral valves being stenotic, I'm talking about the left side of the heart. And when I'm talking about aortic valves being stenotic, I'm talking about the left side of the heart. So guess what? Signs and symptoms that they're all going to have. Left-sided heart failure. Don't make this hard. And they're going to have signs and symptoms of left-sided heart failure no matter whether it is stenotic or regurgitative, because it's all on the left side. And the problem whether the door won't open or whether it won't close is all left-sided failure. You with me? Don't make this hard. If you want to, you can make it hard. Okay, so the valves. There's a chart on page 706. It's chart 35-6. And what I want you to do is look across that chart. The only ones I want you to look at, I'm not interested in no mitral valve prolapse. People walk around with that all the time. They have a little click with it. If mitral valve prolapse gets really bad, gets worse and worse, guess what it's called? Mitral regurgitation. So the ones I want you to learn are stenosis and regurgitation, otherwise known in your book as insufficiency. Stenosis means a narrow valve. Regurg means a floppy valve that won't close. You with me? Okay. Either way, what's the problem we have? Left-sided heart failure. So when you look at that chart, you're going to laugh when you see all the signs and symptoms. There's very few things that make them unique. I don't expect you to know all those murmurs on that chart. Just know they're all going to have a murmur. And I can't recognize the difference between all those murmurs because I don't listen to them enough. Make sense? What do I need you to know? They're all going to have a murmur. Okay. Where the leaflets meet is called the what? Commissure. And so guess what? For a stenotic valve, they do a surgery called a commissurotomy. Isn't that cool? So they just clip where they're fused together so that they can open. Because if they're stenotic, are they narrow and closed? Yes. Now, the other thing they can do sometimes, if they're not a surgical candidate, is they can take them to the cath lab. And you know how they do an angioplasty for coronary arteries? Y'all know what I'm talking about? They can actually take a balloon and open up those stenotic valves. But it's not going to last but about 6 months. But it's surely good for an old person who's not a candidate. It gets them at least some relief for about 6 months, and it's just a visit to the cath lab. Is that cool or what? That's stenotic valves. So the big term, I've told you this before, for repairing native valves, the valves you're born with is a native valve. It's called a valvuloplasty. That's a big umbrella term. Any surgery that they're doing to correct that person's own valve is called a valvuloplasty. The surgery to open up a stenotic valve where they clip the leaflets is called a commissurotomy. All right, you have a ring that encircles your valve leaflet, just like you have an anus. And it's called an annulus. And so if you have regurg where your leaflets are just out there flapping in the wind, is it because your annulus needs to be tightened up? Well, if they're correcting and trying to tighten your annulus, then they are going to do an annuloplasty. Okay? It's called an annuloplasty in your book. And the annulus is that ring that your leaflets are attached to.
Regurg.
And that's for regurg. Okay, it's kind of like your anus when it gets too big. There's a surgery. They can go in there and tighten up your anus. And so, annulus, an annuloplasty is for regurg. I don't care if you remember this, but it's awesome when you're taking report and you know what they're talking about. Now, valve replacements. You ready? Here's what you got to know. It's all you got to know. You got to read that section, but this is really all you got to know. They got two kinds, two flavors, tissue and mechanical. Tissue valves ain't going to last. I think your book said 7 to 10 years. Some books say 15 years. But if you're young and you have a tissue valve, understand you got to go back through open heart surgery and have that thing replaced in about 7 years. Because the younger you are, the more calcium in your blood, the more that your valve's going to get wore out. The younger you are, the more you're going to use it. Okay, the quicker it's going to need to be replaced. The older you are, the longer your tissue valve will last. Mechanical valves, they only have to replace them once if it's good, no defects. But they have to have anticoagulation for the rest of your life, whoever has it. So you got to teach them all about warfarin and all that stuff. You got it? Now, tissue valves come in different flavors. Who cares? But if you're interested, they call them xenografts, and they can do a cow, which is bovine tissue, or they can do a pig, porcine tissue. All that's in your book. I don't care if you know all that. Just know they're either going to have a tissue valve or a mechanical valve. Tissue valves have to be replaced. Mechanical valves last for a lifetime, but they have to have a lifetime of anticoagulation. That's really all you need to know. It's better to replace. It's better to replace. It's better to replace or fix. Hold on. It's better to fix your own valve than to have a replacement. I want you to understand if they're going in to fix a valve, it's open heart surgery. Is that a hard surgery? Yes. And some of these procedures that you read about, like I had a lady tell me she had atrial fib and they need to do the maze procedure and it ain't no big deal. I said, it's open heart surgery. They're going to go make incisions to your heart. Y'all patients don't know because the doctors talk to them because what do? They operate for a living. So they go, we just go in there and do a little maze procedure, da-da-da, and it makes it sound like they're going to the cath lab. I'm like, do you realize they're going to crack your sternum? And you're going to be on life support. So all valve replacements, they're on life support just like an open heart surgery. And if they're going in there to fix a native valve, there are hundreds of different types of procedures they do, kind of like plastic surgery. They go in there and they smooth out leaflets, they clip them, and so they want them to be extremely smooth when they close. So it's not as easy as they make it sound, is what I want you to understand. So as far as care, you don't have to, we're going to learn care of the post-cabbage patient. You don't have to learn care of the patient following a valve, okay? We're just introducing valves in level 3. We're going to cover it, open heart surgery, and care of the valve replacement patient in level 4. relax. What do you need to know about valves? There's
Tissue
two
and mechanical.
kinds. Tissue and mechanical. Tissue has to be replaced in about 10 years. Mechanical's a lifetime, and you need anticoagulation. All right? I'll be tickled if you know stenotic means that they're narrowed and they can't get blood out, which means their cardiac output's going to be down. So if you try to push them, you're going to kill them. We don't do stress tests on patients who have significant aortic stenosis. Does that make sense? Mm-hmm. Yeah, that's why you have the echo first, because an echocardiogram would tell you that. All right, so I have not covered PAD and PVD. I already did, really, the first day. Do y'all understand venous disease is the problem with blood return to the heart? Tell me that.
Yes.
Venous disease, the problem is blood return to the heart. Arterial disease, the problem is blood flow getting down. There's surgery that we can do for arterial disease. Y'all remember that? Just like we do for the coronary arteries, they can go in there and stent arteries in the leg if it's arterial problem. Are there any surgeries we can do for to fix a vein? No. The only surgery that person may go for is like a debridement or something of their wound if it's venous disease, but there are no surgeries to fix venous insufficiency. There's no surgeries. There is surgeries to help fix problematic arteries. They can even bypass arteries in the leg. That makes sense? Remember all your teaching stuff with that. If you will study using this PowerPoint, mainly the high points I told you, if you will read in the book, Iggy is your friend. You will do the cardiac level 3 practice test on ATI. And do your EAQs, because I will kill you if you don't get your points. I'm going to be mad. I'm not going to be mad. I'll be disappointed because I want y'all to do well, okay? And anything with course points is important. All right? Because you got to do, remember, your EAQ for your cardiac and your EAQ for peri-op. Now, what questions? Let me pull this up. Do you have, remember to read these boards? I don't write this stuff up here for my fun. Why do I put this stuff up here on the board?
For us, it's important.
All right, I am your #1 fan of everybody in this room. I am very, very competitive, by the way, and I want my section to do better than anybody's section.
You do too.
And I can't do it for you, but I can certainly help you understand. I promise. And if you promise me you'll get in the book and start reading, and if you don't understand something, there's those old voiceovers, and y'all, they're good after. I'm just telling you, if you don't understand something, it's a good thing to look at. But who can you come to and ask? Because I'm down here almost every day. I stay in this classroom. Why do I do that?
So we can ask questions.
So you can ask questions. I'm trying to make myself available. Now, I'm human, and I'm fussy sometimes, but I'll tell you I'm sorry if I'm fussy. So I'm not fussy that much. But if you will ask me, I will more than give my part if you will give your part. So will y'all give your part? I can't tell you everything that you need to know. There's no way. There's not enough time. So if you will, when you're reading, if you're something you don't understand or know if you should memorize it, who do you need to ask? Can you email me? Can you come up to me and ask me?
Yes.
Okay, there's no excuses. As Florence Nightingale used to say, there's no excuses for you not doing well on this test. All right, do y'all remember what meds you need to know? I beat them into you day one. So what are some common calcium channel blockers? Huh? Huh?
That is what they go back to when they get the cough.
That is a lisinopril is an ACE inhibitor, but I'm glad you brought lisinopril up because that was on my heart this morning driving to work. I know I'm so weird, but lisinopril is one of those drugs that the ER hates because they will come in with something called angioedema all the time from lisinopril. ACE inhibitors one of the real bad things that can happen to patients who take ACE inhibitors is angioedema. And what that means is they start swelling in their tongue, in their throat. It can kill them. And so some people respond poorly to ACE inhibitors. Do you remember the other common things was cough? Nagging cough. And can we give ACE inhibitors which end in pril? Can we give those to pregnant women that are like so many weeks gestation? No. What about the patient? We're still talking about ACE inhibitors. What about the patient whose potassium level is high? Can you give that? No, it's not safe. And then again, when we're talking about calcium channel blockers, we're talking about things like cardizem. We're talking about, that's the other word for that you have to know is diltiazem. Y'all learn those, don't you? Diltiazem. The other word for diltiazem is cardizem. Another very common calcium channel blocker is amlodipine. Y'all remember that? Okay. And what's the other word for that Ms. Cooper knows? Amlodipine is Norvasc. That's a calcium channel blocker. Probably the most common calcium channel blocker that we see given is diltiazem. Now remember, with calcium channel blockers, we give those for rate control sometimes to decrease the rate. It also does what to the blood pressure? Brings it down. Okay. So beta blockers, I thought we beat the LOL into, didn't we? And y'all remember check heart rate and blood pressure. Y'all remember that, right? Yeah. What are my other ones? If it's a non-cardioselective, we got to worry about
Diabetics and
asthma, diabetes. Y'all remember these things? Okay. What about thrombolytics like alteplase? Alteplase is a common TPA. We also call thrombolytics. You'll hear it called alteplase. You will hear thrombolytics called TPA, and we also call them clot busters. So thrombolytics dissolve clots, and they're a Band-Aid approach in cardiac. Y'all remember that? Mm-hmm. And there's more reasons not to give them than to give them, and I wanted you to know the absolute contraindications. So what are some of the absolute, we will not give it?
Stroke, previous surgery, previous brain.
Thank you. Okay, present hypertension, like bad elevated blood pressure at the present time. A history of hypertension, so what? If it's controlled, good. Is that a problem? No. If their hypertension is just by history and it's controlled, they're okay. So what if, do they have to have chest pain greater than 30 minutes?
And a STEMI.
Yes, and a STEMI. So it has to be a STEMI. Chest pain has to be greater than 30 minutes. What's the cutoff time? It's been too long. 6 hours is your cutoff time. If they have had pain greater than, or symptoms greater than 6 hours, they're not a candidate. That makes sense? Okay. So do you think you need to know who's a candidate and who is not a candidate? Mm-hmm. You go visit that page. Yes. What else is on your objective that you are fearful of? What is your muddiest point? And if y'all want me here, I'd stay here till 3 o'clock. Is that where I'm supposed to be? Because some of them said they was getting out at 2 and we didn't need this many hours. But I was trying to be fair to y'all, so that's why I was trying to wrap it up. But I can be here till 4 o'clock if you need it.
I'm still kind of confused on this. So with the valves, you have your...
Let's talk about valves. Let's go through them. You ready? Let's talk about it. If you're ready, I'm ready. Y'all aren't mad at me, because I can't have y'all mad at me.
No.
Y'all keep going. Y'all good?
Yeah, sorry guys, that was just me.
Well, I don't think you really have to be according to your syllabus, but I'm going to be. But I am going to be. But I won't be mad at you if you leave, is what I'm trying to tell you. Okay? Is that fair? Okay, I can teach all day long and not even have to teach or eat. I know, you're like, please God, don't do that to me. You got a cute face for this Reggie. She's got the cutest face for this Reggie. I wish y'all could see her. Alright. I wish y'all could see how y'all look at me sometimes. Alright. When you're talking about... Sorry. Do I have a booger or something?
No.
Okay.
Can we go pee before we start?
Yes. All right. That's why I was wrapping it up because I was heard that. Well, Miss Clemens, we done wrapped up and came back. They're going to break.
Okay.